Jackie Doyle-Price to reply to the debate.
Thank you, Mr Speaker, and I congratulate the honourable member for Kingston-upon-Hull on securing this debate to mark a historic occasion, as she says, the 50th anniversary of the passing of the Abortion Act. As she's explained, the Act was introduced as a private member's bill by the then honourable member for Roxburgh, Selby and Peebles, now the Right Honourable Lord Steele of Akewood, and clearly defines the grounds under which an abortion may be carried out in England. As she's explained, that with the exception of emergencies, where it is necessary to perform an abortion to save the life of a woman, 2 doctors must certify that, in their opinion, which must be formed in good faith, a request for an abortion meets at least one ground set out in the Act, and that there should be an agreement as to which ground this is. She raised in her remarks whether it should remain the case that it's still 2 doctors. Well, while ever that remains the law, clearly it is. From my perspective as a minister, my emphasis is that we deliver the safest possible treatment for women in accordance with that law. She raised some very important issues with regard to waiting times, which I'd like to go away and reflect on, because I'm sure everyone in this House agrees, no woman undertakes a termination lightly. For many of them, it's extremely traumatic. So it's incumbent on all of us to make that as the least painful as possible, the least traumatic as possible, and as safe as possible. And central to being as safe as possible, it is that it takes place as early as possible.
The Minister talks about the requirement for 2 medical practitioners to give agreement. And doesn't she agree that with actually a poll last week by 2,000 adults, Comrade's poll, which showed that 72% of the public think abortion should continue to be subject to that legal requirement, because that ensures protection for women, particularly in an abusive relationship. That might be the only opportunity they have to talk to someone in a safe environment about pressure that they might be being put under to have an abortion.
Minister.
I think central to this is that we need to be satisfied here in Parliament that the regime we have is safe for women. And at the moment, we have a law that's been on the statute book for 50 years, and until Parliament decides to change that, that is the law that I will implement as safe as possible. I hear many quotes about polls, but frankly, when it comes to this issue, on which people have very strong views, I think we just need to be sure that we maintain the law with integrity. But thanks to the dedication, hard work and expertise of the doctors and nurses working in abortion clinics, termination of pregnancy is now an extremely safe procedure, and in marked contrast to some of the statistics that the Honourable Lady outlined before the Act. Data for 2016 show a complication rate of just 1 in every 630 abortions, which is even substantially lower than just 10 years ago, when the rate was 1 in 500. The choice of early medical abortion, which is less invasive than a surgical procedure and does not involve the use of anaesthetics, has helped increase the overall percentage of abortions performed at under 10 weeks gestation from 68% in 2006 to 81% in 2016. And clearly, the more we can encourage that, that will be far better for the welfare of women who are undertaking terminations. What is that?
Minister for giving way and congratulate my honourable friend on securing the debate. But while the Minister is talking about what happens to a woman during the procedure and how much care should be taken, does she share my concern that was highlighted in the Spooks report last week, Abortion and Women's Health, about the poor provision for counselling and support that women need who suffer any mental distress after they've had an abortion, that it's seriously lacking in this country?
Minister.
Well, at the risk of being really controversial, I think there's lots of elements of counselling for women that are seriously lacking, and I think it possibly reflects the fact that quite often the decisions about the welfare of women have generally been taken by men. And it's great that we are now in a position where there's lots more women in this House able to actually influence exactly that. Yes, indeed.
Thank the Minister for giving way. Does she agree it's absolutely imperative that we offer women choice in terms of the decisions they take about their body? And will she give an undertaking this evening to investigate perhaps why the government thought it was appropriate to award the largest sum of money from the Tampon Tax Fund to an anti-choice organisation?
Minister.
I understand that the Honourable Lady feels very, very strongly about this issue, and nobody can doubt her passion and commitment to women's welfare on these issues. My understanding about the grant she refers to was that it was very strictly towards the support of women who chose to go through with birth. I'm happy to look at that further. I'm not entirely sure that it was the largest donation, but I will be happy to look into that. But she's right when she says there should be a genuine choice. We don't want anyone to feel that they can't have an abortion any more than they feel that they have to. We really want women to be able to make informed choices and feel empowered to have the child if that's what they would like to do. The important thing is that we empower women. That's the whole purpose of what we're trying to do here. We empower women and we allow them to make choices which are safe for them. Since the Act was passed, there have been regular calls from all sides of the debates for changes to legislation, and the Honourable Lady's outlined her views very clearly today. As she's referred to, this government and previous ones have always viewed the matters for legislative change as one for the House on which to take a view, and there are no plans to change that. The Act was last amended in 1991 by the Human Fertilisation and Embryology Act 1990. This reduced the time limit for most abortions from 28 weeks to 24 weeks. No time limit applies where there is a substantial risk that the child will suffer from a serious handicap or that the pregnancy would cause grave permanent injury to the physical or mental health of the mother or put her life at risk. So amendments are possible, and ultimately it is Parliament that decides the circumstances under which abortion can be legally undertaken, but the government will also always ensure that regulation works to make that as safe as possible. The Honourable Lady has outlined very clearly her belief that the abortion should be decriminalised, and the government will no doubt take a view as and when she brings forward her bill, as indeed will the rest of the House. But it is true that any abortions conducted outside the grounds in the 67 Act do currently remain a criminal offence. And as I say, there is no intention for that to be dealt with by anything other than a free vote. Turning now to the impact of the Act in practice, it is important that we remember that in the years before the Act, abortion was indeed the leading cause of maternal mortality in England and Wales. For example, the first confidential inquiry into maternal deaths in 1952 reported 153 deaths from abortion alone. The most recent confidential inquiries report found there were 81 reported deaths in 2012-14 for all direct causes of maternal mortality, such as obstetric complications, interventions and omissions. So since the Abortion Act came into force, women in Great Britain have had access to legal and safe abortion services. Yes, indeed.
Those who committed suicide as a result of having an abortion and the effect it had upon them, does it include those people?
These figures include those who've actually died as a result of maternal complication. I'm not aware of any figures which detail suicide, but again, we need to look at the whole issue of counselling around women when they're facing either any kind of unwanted pregnancy. In 2016, 98% of abortions were funded by the NHS, whereas in 2006, just 87% were NHS funded, which shows that the NHS is providing more and more of this service. 92% were carried out at under 13 weeks gestation, and 81% were carried out at under 10 weeks, which again illustrates that it is becoming safer. 62% were medical abortions, which is more than double the proportion in 2006, again a good sign of progress. The data I've just quoted clearly shows that improving access and choice within the existing framework can be achieved, and I'm sure that all honourable members will welcome the fact that the vast majority of abortions are taking place at earlier gestations, which is safer for women and offers increased choice of medical abortion. On the issue of home use, it is currently the case that abortions in England can only be performed in an NHS facility or a place approved by the Secretary of State for Health. At present, a patient's home is not currently an approved place for abortion. Now, I am aware that the Scottish Government has recently granted approval for the second stage of early medical abortion treatment to be undertaken in a patient's home in certain circumstances. Now, as I've said repeatedly, our overriding principle is that all women who require abortion services in England should have access to high quality and safe care. However, we will continue to engage with women and with stakeholders on ways to make our safe and regulated services even more effective. Of course, a key part of an abortion service is providing information and services to enable women to make informed decisions and support good sexual health. This includes information about and provision of contraception and testing for sexually transmitted infections. Abortion providers should be able to supply all reversible methods of contraception, including long-acting reversible methods, which are the most effective, and offer testing for sexually transmitted infections as appropriate. Before the woman is discharged, future contraception should have been discussed, and as far as possible, the chosen method should be initiated immediately. All women should be offered testing for chlamydia and offered a risk assessment for other sexually transmitted infections such as HIV and syphilis. Now, provision of effective contraception is essential if we are to make progress towards our ambition to reduce unintended pregnancies in women of all ages. And for women of age 24 and under, we have seen significant reductions in the abortion rate, most notably in the under 18s, where the rate is reduced from 18.2 per thousand in 2006 to just 8.9 in 2016. Rates in women aged over 24 have remained stable or increased slightly, and we know we have more work to do to ensure that we see improvements across all age groups. Just to bring my remarks to a close, as we are short of time, I think what we've seen is that over the last 50 years there have been significant increases and improvements in women's health and in the regulation of abortion and in the safety of abortion. And it's appropriate that we look back and take stock and congratulate ourselves on that. And in going forwards, that we continue to ensure that the way we allow for legal abortion is at all times safe and well regulated.
The question is that this House do now adjourn.